Right.
Yes.
So do you know why you get a basic ECG? Do you know why you get a PQRST? You know about PQRST?
Yes. Yes.
So in a normal ECG you're going to get a P. It was like this. So that would be kind of a normal ECG cycle, wouldn't it? So the P is that wave there. The Q is this bit where it goes down.
Yeah.
There's a line along there called the isoelectric line. So that's kind of the isoelectric line there,
Yeah.
where everything goes below and comes back to. So we've got P, the Q is the bit that goes down. Q, R, the bit that goes down here is the S. So collectively we've got the Q, R, S complex together. Then this wave here is the T wave. So we've got a P, Q, R, S, T in that order. And what's actually happening is individual myocardial cells, when they're at rest, are electrically negative on the inside. So they're negative inside and they're positive outside. In this state we say that the cell is polarized. It has two poles, like a battery, a positive and a negative pole. So this cell is polarized. It's got a negative inside, a positive outside. Now, muscle's pretty stupid. It's not like nerve cells that are clever. It has to be told when it's time to contract. So when it's time for a muscle to contract, electrical signals will change the polarity across the cell membrane of the individual myocardial cells. And they'll become positive inside and negative outside. So ions, charged atoms, will alter their distribution across the membrane, reversing the polarity inside the cell and outside. So in this state the cell was polarized. When the polarity changes we say the cell is depolarized. So in this state the cell is depolarized. It is depolarized. And when a muscle cell depolarizes in health, it will contract. So this will be associated with contraction. The depolarization, it will contract. But if a cell will only contract when it depolarizes, this process here would be depolarization. If a cell will only contract when it depolarizes, and it needs to contract again in 0.8 of a second for the next cardiac cycle, can you see if it's going to contract when it depolarizes, and it's already depolarized, in order to depolarize again it must first repolarize.
Yeah.
So first of all it has to repolarize. That process is called repolarization. So the P wave is the electrical activity as detected on the surface of the body that occurs as a result of atrial, myocardial depolarization. It's the depolarization of the atria. In other words, it's when the atria contract. So the P wave is atrial contraction. Then the QRS complex represents the depolarization of the ventricular myocardium. So the QRS complex is the electrical activity as detected on the surface of the body that occurs as a result of ventricular myocardial depolarization. That's why we get a QRS. In other words, in health, the QRS means that the ventricles are contracting. It's not actually the ventricular contraction we see. What we actually see is the electrical stimulus, the electrical depolarization, which causes the contraction of the ventricles. That's what we actually see. And then the T wave is the ventricular myocardium repolarizing, going back to normal. So the T wave is the electrical activity as detected on the surface of the body. That occurs as a result of ventricular myocardial repolarization. So ventricles going back to normal. And the electrical activity that initiates this is generated in an area in the right atrium called the sinoatrial node, or the pacemaker of the heart. That's where this rhythm comes from. Now that rhythm is modified by external sympathetic and parasympathetic stimulation from sympathetic nerves and from the parasympathetic nerve that supplies the heart also. What is the name of the parasympathetic nerve that supplies the heart?
Vagus nerve.
It is, well then it's the vagus nerve. What number cranial nerve is that?
10.
And why is it called the vagus nerve?
Because
What does vagus mean?
it's
Vagus means bored.
weak.
Bored.
Bored?
Yes.
It's long.
Hmm?
It's very long.
No, it doesn't mean that.
Very weak impulse.
No, it doesn't mean that.
Give vagal tone.
No, it doesn't mean that.
It's suspense.
Come on, I don't want to have to ask Simon. I've told him you're clever students, which of course you are, you're doing very well. Vagus is from an old Latin word that means vagrant. And a vagrant is like a tramp, they wander around.
Oh,
Yeah. So vagus actually means the wandering nerve.
wandering nerve.
Yeah. So it wanders down to the mouth, then it goes down to the heart, then it goes down to the stomach, then it goes down to the intestine. It just kind of wanders around the body. That's why it's called the vagus nerve. And that's good. Anyway, the vagus nerve, the sympathetic and the parasympathetic, can influence heart rate. The actual sinoatrial node has an intrinsic contractile rate of about 90 beats per minute, actually. 90 depolarizations a minute. So most of the time it's being slowed down. So Simon's heart rate there was about 72. That's because his vagus nerve was inhibiting the rate of contraction of his sinoatrial node. But this lesson we're not going to do about the way the impulses go through the heart, but we are going to notice that this rhythm is generated in the sinus node, therefore it's called a sinus rhythm. That's normal. This is why we call it a sinus rhythm. So what is a sinus rhythm? Well, it has a P, a QRS and a T in the right order, and it's fairly regular. That is what a sinus rhythm is. And to have a proper sinus rhythm, the rate must be between 60 and 100 beats per minute. So physiologically, a sinus rhythm is described as a PQRST in the right order, fairly regular, with a rate between 60 and 100 beats per minute. Now, if you have a PQRST in the right order and it's fairly regular, but the rate is less than 60 beats per minute, that can still be a physiological rhythm. For example, if someone's very fit, they might always have a slow heart rate. Or when you're asleep, your heart rate can go slow. That's called a sinus bradycardia.
Yeah.
It's normal. Sinus bradycardia can be normal, but it's considered slow if the rate is below 60. So a sinus bradycardia has a PQRST in the right order and it's regular and the rate is less than 60. A sinus rhythm has a PQRST in the right order and it's fairly regular and the rate is 60 to 100. If you've got a PQRST in the right order and it's regular, but the rate is over 100, again, that can be physiological. If you go running, that will happen. If you're excited or afraid or an emergency situation, that will happen. And we call that a sinus tachycardia. So they're the three normal sinus rhythms. Yeah.
So how can we distinguish which one is physiological and which one is pathologic?
Okay. Well, let's take an example of that. One example of that is the cardiac arrest rhythms, which are obviously going to be pathological. So it's worth learning 3 or 4 cardiac arrest rhythms. So the first cardiac arrest rhythm, the most common one, what's the most common form of cardiac arrest?
Asystole.
Asystole is a relatively rare form of cardiac arrest. You do see it in trauma especially. If someone's exsanguinated, very low on blood, you can see it, but you don't normally see. Sometimes you see asystole in coronary care situations, but not that common.
Ventricular fibrillation.
Ventricular fibrillation is the most common. And this looks like this.
Yeah.
So there's polarization and depolarization, but the ventricles are just doing this.
Yeah.
So put your hands together like this. Right, this is ventricular fibrillation. Go on, otherwise you'll forget. No, try it, you'll forget otherwise. Because you've got to teach the junior students this.
Yeah.
And that's a fairly coarse ventricular fibrillation.
Yeah.
And you can see what it's doing, can't you? The whole thing's fibrillating. And of course that's associated with no cardiac output. But over time this tends to become finer like this. You get a fine ventricular fibrillation. So this is coarse ventricular fibrillation. Come on, Simon, do the actions, please. Right, coarse ventricular fibrillation. Right. This is fine ventricular fibrillation. Yeah, it's not moving as much. Yeah. And clinically it's important to know because it's very easy. If someone's in fibrillation, can you see you need to defibrillate?
Yeah.
Get it right, make sure they are in ventricular fibrillation. They'll also be unconscious and they'll have no pulse. Fine ventricular fibrillation, it's harder to shock them. Very often you might need to oxygenate them, you might need to give CPR, you might even need to give some adrenaline to course up the ventricular fibrillation to make it more shockable. But so that's the most common cardiac arrest rhythm.
Then the prognosis for the fine one is poorer than the left one.
Correct.
Yeah.
But in a good coronary care situation, that is manageable. In a hospital resuscitation situation, you would expect to be able to revert that rhythm.
So there, for the two cases, there will not be a clear, regular QRS complex?
Absolutely not, absolutely not. Ventricular fibrillation is a completely chaotic rhythm. There will be no discernible, organised rhythm. What's happening is multiple areas of the myocardium are depolarising chaotically and irregularly. And you get no coordinated contraction. So to get coordinated contraction with a normal QRS, the ventricles have to be doing this. Can I do that one? That's pumping the blood out. Right? If they're doing that, can you see they're not doing that?
Yes.
Yeah, that's why it's a cardiac arrest situation. Now there's another situation that can be a cardiac arrest situation. And
Sometimes ventricular tachycardia.
yeah, that looks like this. Ventricular tachycardia. Now, sometimes the patient with this is unconscious. Other times they might not be. Now, this responds superbly to defibrillation, but you've got to make sure the patient's unconscious first. Because it's not very nice getting 2,000 volts or 3,000 volts through your chest when you're awake. And ventricular tachycardia is going to be, well, this is sinus rhythm, isn't it? This is ventricular tachycardia. There's no time for the ventricles to fill up. So there's no cardiac out, very little cardiac. The patient might have a blood pressure of 30 or something. But it's not good. And if this isn't treated, pretty soon it will change into this. If this isn't treated, it will change into this.
But what is the reason?
The reason is usually an ectopic electrical focus in the myocardium, which is generating impulses. So there's a pathological lesion in the ventricular myocardium that's generating electrical impulses more quickly than the impulses are coming from the sinoatrial node. So it's taking over. It's what we call an ectopic electrical focus. Ectopic means something is in the wrong place. Like an ectopic pregnancy is in the fallopian tubes, isn't it? It's in the wrong place. So if there's a pathological electrical focus in the ventricular myocardium, that can start generating waves of depolarization. The rest of the ventricle will try and copy. It will move across the ventricular myocardium, which is physiologically called a syncytium, and the whole thing will start contracting pathologically. So normally, the most common in my experience of this, and this indeed, is areas of abnormal electrical activity in the myocardium usually caused by myocardial infarction. A myocardial infarction, of course, is caused by coronary arterial thrombosis, which is usually caused by unstable, destabilized atheromatous plaques. And atheromatous plaques is caused by bad diet, smoking, and all the things that we don't do because we're clean living. It's also genetic, though, so anyone can get it. Right, another cause of cardiac arrest is asystole. Now, A means without, systole means cardiac contraction. So this is a normal rhythm, that's sinus rhythm. This is coarse ventricular fibrillation. This is fine ventricular fibrillation. This is ventricular tachycardia. This is asystole. Watch really carefully. When we bury people, they're in asystole. Unless, of course, you've got it wrong. That is a death rhythm. And ventricular fibrillation will eventually, this will become finer and finer until it becomes asystole, actually. So eventually, all of us will end up in asystole. I hope it's a long, long time, but eventually we're all going to go into asystole. And clinically, this is hard to revert. You need to treat the causes of asystole. So in trauma, for example, if it's caused by exsanguination, if it's caused by an acute hypovolemia, we need to get some fluid into them pretty quick and then try and restart the heart. We need to do CPR to oxygenate the myocardium and the brain. We often need to give adrenaline because the only chance of getting a patient back from asystole is to get them back into a ventricular fibrillation. We have to irritate the myocardium enough to get it back into ventricular fibrillation, then we can shock them. And it doesn't happen very often. Usually this is irreversible. Having said that, I think I did get one patient back from asystole once. But maybe it wasn't asystole, maybe it was just a very fine ventricular fibrillation. So they're examples of cardiac arrest rhythms. Now, a normal ECG, as we've seen, has got the P, QRS and the T wave. That's normal. But with a 12-lead ECG, there's two very useful things the 12-lead ECG can show us. One is it can show us if an area of myocardium is infarcted. That would be a ST elevation myocardial infarction. A STEMI, an ST elevation myocardial infarction. Now if that happens, as the name implies, there is ST elevation. And what this means is that we have a P, but the section between and that's the S and the T there, that bit is elevated like that. So this bit here is the area of elevation. And the area of elevation will vary depending on the position in the myocardium that is infarcted. So if we've got a 12-lead ECG, from that we can work out whereabouts in the myocardium the infarction is, whether it's an inferior myocardial infarction, an anterior lateral myocardial infarction, or whatever it is.
But it's
So-
just sorry to interrupt.
Fine.
But is it the ECG just can reveal there is a presence of STEMI, but not accurately which part of the heart is?
No, it can accurately tell which part of the heart it is.
By the timeline?
No, by the leads that the ST elevation occurs in.
Oh,
So remember we said that you're looking at the heart from different directions, AVR, AVL, AVF, 1, 2, 3, 1, 2, 1, 2, 3, 4, 5, 6. So you're looking at the heart from lots of different directions. Now it takes a bit of practice, but the reason this works is any electrical activity which is moving towards an electrode goes up, and any electrical activity which is moving away from an electrode goes down. So if you look at the different leads, you can work out which part of the myocardium is affected. I'm not going to tell you how to do it just now because this is just a quick lesson.
okay.
But you can do that. So we're looking for ST elevation, which indicates infarction.
Yeah.
Now the other common thing we see is ischemic changes.
Yeah.
Ischemic changes. And with ischemic changes, very often we get ST depression. And you can actually get this with non-ST elevation myocardial infarctions, where you get ischemic areas in the heart. Or if someone's got stable angina and we put them on a treadmill to exercise them, if we can actually induce the ischemia in the myocardium, then you can see the ST elevation at the time. So if a patient's complaining of chest pain, they think, oh, I've got chest pain, then immediately do a 12-lead ECG. If that chest pain was caused by ischemia, it will diagnose the ischemia because you'll see the ST depression in the relevant leads of the ECG. But the ST elevation will only be there when there's active ischemia. The rest of the time you won't see it. And what we see is, as normal, we have a P, QRS, and a T. What you see with ischemia is goes like this, goes up, but this goes down too far like that. And this bit here represents the depression. So an ECG where there's infarction will look like this. That will be infarction, ST elevation. Ischemia will look like this. As ST depression. They're the two most basic things to learn when you're interpreting 12-lead ECGs. So rhythms, it's very good to look for, is there PQRSTs or is there a cardiac arrest rhythm? There's many other rhythms as well, of course. Another common one that we see is atrial fibrillation. In atrial fibrillation, the atria are fibrillating, but the ventricles aren't. And what we see is, we see the atrial fibrillating there, and then we just get irregular QRS complexes. It's an irregular rhythm, and we get an irregular pulse as the atria fibrillate. It's not sinus rhythm because there's no P wave, because the atria are fibrillating, they can't generate a P wave. And it's not sinus rhythm because it's not regular, it's irregular. There's no PQRST in the right order and regular. There is a QRS. If there wasn't a QRS, the patient would be in cardiac arrest. But there's no P, and the QRS, the PQRS don't follow in a logical order. In fact, there is no P wave. So what you need to do is practice lots of normal ECGs in each other, look at normal rhythms, and then when you do abnormal ones, you'll see that the abnormal ones are different. And with a bit of practice, you can work out where in the heart the ischemia or the infarction is occurring.
I want to ask how about when doing CPR, how you get a normal wave in the cardiac monitor?
Right. If you do CPR, you won't get a normal wave on the cardiac monitor. What you'll actually see on what you'll actually see on the ECG is a bit of a mess. You'll get a lot of electrical interference on the ECG, and you'll also probably be able to see the underlying rhythm that the heart is in. But what you will get with CPR is you've got the vertebrae there, you've got the sternum on top, and you're squashing the heart in between. That means the heart contracts and then is able to relax again. So if you're doing good CPR, you won't get a PQRST rhythm, but what you will get is a cardiac output. So if you're doing good CPR, you will get a carotid pulse and you will get a femoral pulse. But it's caused by the compression of the heart between the sternum and the thoracic vertebral column. You don't get the normal electrical activity because the patient's actually electrically, they're in a cardiac arrest.
Just like the cardiac monitor will still show a VF or something like
The cardiac monitor will just show electrical interference. Yeah, that's all it will show. There is another cardiac arrest rhythm where you actually get a rhythm that looks normal, because sometimes the electrical activity in the heart can carry on, but there will be no associated cardiac output. Again, this tends to happen in severe hemorrhage. It does happen in some coronary care situations as well. That's called pulseless electrical activity, where you get the electrical activity but no pulse. So when we're assessing patients, what we've got to do is always compare the ECG with the way the patient looks and with the patient's pulse. You've always got to take them together. The ECG is not a way of assessing patients, it's only a little bit of a way of assessing patients. It's only part of the whole clinical picture. The most important thing in assessing a coronary patient is the colour of their face, how alert they are, what kind of pulse they've got. Then this is a little bit of help as well. But it's not a substitute for your clinical judgment. The most important thing you can learn is your clinical judgment. Machines are only for fun. They help a little bit.
But why there is no pulse for PEA?
There is no with pulseless electrical activity, there is no pulse, but there is a PQRST.
Why?
Because you are getting depolarization of the myocardium as normal, but because the myocardium is diseased or hypoxic or hypoperfused, it's just sitting there doing nothing. The muscle is unable to respond to the electrical activity. And again, that's quite a dangerous arrest rhythm. If someone's in pulseless electric activity, you've got to treat the underlying cause of the pulseless electrical activity, treat it basically as an asystole, hope you can get them back into ventricular fibrillation, and only then can you shock them. But again, it's often associated with a poor prognosis. But because it happens quite a lot in trauma, and it's often young people, we make exhaustive efforts to try and get them back again. So we'll give them blood transfusions, we'll give them fluid, we'll give them CPR, we'll give them adrenaline, and we'll try and shock them.
And in the worst case scenario, we'll open their chest and do...
That's what they used to do in the old days.
Yeah.
I think it was in the Korean War. When someone's heart stopped, they used to have to open the chest and put the hand in and squeeze the heart. Then someone thought, ooh, why do we have to do that? Why can't we just squash it between the sternum and the vertebrae? And that's when CPR was invented.
Oh, I see.
Yeah.
But it's a dangerous strangulations of blood vessel when you just open somebody's chest and squeeze them.
Well, opening the chest is associated with many complications.
Yeah.
But the major vessels of the mediastinum, you can grab the heart without compressing the major vessels in the mediastinum. That can be done. That can be done. But we'll do that as an advanced trauma course. We won't do that today. But it can be done.
Yeah, but ego CPR.
No, more questions. This is good. I like questions. Go on.
Really?
Yeah.
Is the atrial myocardial depolarizations be seen in the ECG programs?
Absolutely. The reason you're getting the ECG is because of the myocardial depolarization.
But is it? There is anything related to the atrial depolarization?
Yes, the P wave is atrial depolarization. Oh, now I know what you're asking. You're asking is there atrial repolarization?
Oh, yes.
That's what you meant to ask, isn't it?
It's masked by the QRS complex.
Absolutely, yeah.
Is it matched?
The answer is yes, you do get one. But it occurs just here. Like that.
Okay.
And you don't see it because the phrase is, so that's the atrial depolarization. That's the atrial repolarization. It's a very good question. You knew the answer already, but the question is a good one. Why don't you see atrial repolarization? And the answer is it's there. That's when it occurs. So you don't see it because the QRS is going on at the time. What we say is that the repolarization wave of the atrial myocardium is buried in the QRS complex, so you don't see it.
So for the tachycardia of the ventricles, there is also a clear QRS complex between
In ventricular tachycardia, these are QRS complexes.
all of them.
They are, but they're described as web complexes. They are wide, they're early, and they are bizarre. They are not physiological QRS complexes. And there is no time for effective ventricular filling, so they're associated with a significantly reduced cardiac output. This patient will either go into immediate cardiogenic shock, or they will actually be unconscious. Actually, if they're unconscious, it's good, because if you shock them, the first time you shock them, this reverts back into sinus rhythm. This is the easiest one to treat. If they're still awake, you have to sedate them and then shock them. Well, that's the safest way to do it anyway.
Then for patient with MI, the P wave and QRS complex will also change.
No, MI, if it's a non-ST elevation myocardial infarction, this will look normal or show ischemic changes. If it's an ST elevation myocardial infarction, you'll get the ST elevation, so that will alter the shape of the QRS complex, but you're still going to get one. If you don't get one, that means the heart's not contracting, that means you've no cardiac output, that means you've no blood pressure. And that, by definition, if you've got zero blood pressure, by definition that would become a cardiac arrest situation.
How about when you're getting usually we have one ectopic focus, or just like you have many?
Okay, yeah, you can get ectopic beats in a normal ECG, and that can be a physiological ectopic focus which gives off an ectopic beat. Sometimes we call them ventricular ectopics, and in older people they become more common, and in coronary care situations we describe those as being normal. It would only become abnormal if you had a few together and the patient might become acutely hypotensive. But to get a few ectopic beats from time to time, especially in older people, we consider that normal. Many people do it. So if you get 160, 65-year-olds, you put them all on an ECG, quite a lot of them are going to have some ventricular ectopics. But most of the time the patient won't be aware of it, so we'll count them as normal. It only becomes abnormal if it's caused by some cardiac pathology. We're more concerned if there's a lot of them in younger people. That could be a feature of some cardiac disease.
So is it true that MI are associated by my first degree and second degree heart block?
Well, heart blocks can occur whenever there is disruption to the internal electrical conducting system of the heart. So as you know, normally you've got the sinoatrial node, the internodal tracts, you've got the atrioventricular node, the atrioventricular bundle, which used to be called the bundle of His, the right and left bundle branches, and the Purkinje fibres. Now in ischemic heart disease, it's quite possible that the blood supply to an area of myocardium which contains part of the conducting fibres could be ischemic or infarcted. That means that the electrical conducting system is going to be blocked at a particular point. And that's what gives rise to heart block. Now if you go and work in coronary care, you actually learn that there's 3 grades of heart block. There's grade 1, type 2 and type 3. The first one, grade 1 heart block, is just a prolonged interval between the P wave and the start of the QRS complex. But then you get 2 types of second degree heart block and 1 type of third degree heart block. But they're all caused by physiological disruption to the internal electrical conducting system of the heart, which is blocking the normal flow of impulses from the sinoatrial node all the way down to the Purkinje fibres that actually innervate the ventricular myocardium.
And then is it usually irreversible?
Sometimes they get better. You're likely to get full recovery if you can thrombolyse, or do quick percutaneous coronary arterial revascularization. So it depends how quick you are in your coronary care situation. You can get the physiology back again. Sometimes in the days after, you can get a degree of recovery if the conducting pathway is not actually infarcted. Other times, if there's severe heart block, we have to go in and do cardiac pacing. And in cardiac pacing, we normally pass an electrical wire into the area of the cardiac apex down the bottom and electrically pace it artificially. But that would be a last resort. So the key thing with ischemic heart disease is to give thrombolysis or PCI as quickly as you can and prevent the areas of myocardium which contain the conducting tissues from infarcting in the first place. You've got to be quick. Just do whatever's quickest. If you can do PCI quick, do it. If it's going to take half an hour to set up PCI, thrombolyse them if you can do it in 2 minutes.
Well, the standard in this country is 30 minutes instead of chest pain, right, to a needle in the arm to thrombolyse them.
It doesn't always happen.
It doesn't always happen, and if your immediate response would just give them 300 milligrams of aspirin.
Give some aspirin as well, yeah.
Yeah.
But if you can do it in 3 minutes, it's better.
Yeah. Oh, absolutely.
That will improve the
Absolutely.
prognosis. It's how quick you can do it. Good. 11:30 already. One more question. Yep.
In the case of ST elevated MI, the graph is elevated.
The ST segment is elevated, so that would be ST elevation MI.
Yes, is it because the myocardial is unable to do the repolarization?
It's a very good question. What you're asking is why does an infarction generate an area of ST elevation?
Yes.
That's what you're asking. Right, the answer is quite complicated. The answer is that if an area of myocardium is infarcted, there's not going to be any electrical activity in that area. So what you're actually seeing when you look through that direction is the opposite wall of the heart. So the heart's got two walls like that. Normally the ECG would be seeing that wall, but now you have a dead bit in that wall. There's a dead bit, so there's no electrical activity there. So what you're actually seeing is the other wall. It's the activity in the other wall. What we say is an infarction is an electrical window. You're actually looking straight through it to the other wall. So the reason you actually get the ST elevation is it doesn't actually come from the infarcted area. It comes from the fact that the infarcted area is an electrical window, and you see straight through that to other functioning areas of the myocardium. That's a very good question.
Thank you.
Very good question. It was the last one though.
Yes,
Right, okay.
thank you.
Right, Simon's going to talk to you now.
No,
You get those videos